Hi, I'm Dr. Tynes. I'm the Associate Director for the Psychiatry Residency Program here. I'm also the Medical Director for the Mental and Behavioral Health Service Line at Our Lady of the Lake. I've been asked today to talk a little bit about a project that I'm heavily involved in called Collaborative Care. So collaborative care is a paradigm for bringing medical care to the primary care setting in certain instances anyway, and has been studied in a way that helps us hone in on exactly how to approach this type of care to get the biggest bang for the buck. It consists of both a screening component where we screen up front the primary care patients, usually for depression, plus or minus anxiety. Then the primary care team will confirm that someone's got a positive screen, they may have depression, and refer to a behavioral health provider, typically a social worker, who then immediately, if at all possible, will meet the patient while they're there for their primary care appointment and connect with the collaborative care program. The beauty of all of this is that it is housed in the primary care setting, and it helps leverage the psychiatrist's time. And by that I mean the primary care doctor remains in charge of the care of the patient. He writes the medications, follows up on side effects, changes the dosing. The psychiatrist, in this case it's me for most of our clinics, will make recommendations, but I don't actually see the patient or pick the patient up to become their doctor. I review their materials. Electronically, I can get on the chart, look at labs, imaging, their other medications, their history, their medical disorders, and then connect in a team staffing with the behavioral health provider who has seen the patient. What this ends up doing is making the best use of your psychiatrist's time, but it treats patients where they're willing to be. Now, it's not all things to all people. It's a way of grabbing a big chunk of patients that need mental health care and typically won't go get it in other settings. They won't follow up with referrals for any number of reasons, and are not comfortable doing that, but they're comfortable coming to see their primary care doctor. About I think 2 years ago now, I began to have residents come with me, and coming with me many times just means sitting in my office, because a lot of this is done electronically, even long distance, even the staffing meetings. But the residents began shadowing me, and we've gradually increased their responsibilities so that now it's common for the resident to take on some of the cases with me supervising, so they become me, so to speak. And they understand that they may get a message or a call on the off days, which is my life. I may get a text from the primary care doc asking clarification on a dosage or whatever. They know that I do that, and so that's part of learning how to do this business. And I'm hoping that I'm able to take it one step further in the future with our residence clinic, where the internal medicine residents are the primary care docs, that we are able to have the psychiatry residents be this collaborative care physician for the primary care residents. That's my vision in the future. We're not quite there yet. But I believe that this whole paradigm is a big part of the future of psychiatry and treating patients where they are. And having this experience, I believe, will help set our residents apart when they're trying to find a job and looking at their various possibilities out in the job market.